We will focus on degenerative diseases because tendons are biomechanically exposed structures, and therefore almost all diseases of a tendon are in some relationship to overuse. And the point is to find out what is behind the overuse and why is there any underlying disease. And of course we should have a focus on outcome-oriented imaging. This here is a synoptic overview what may happen to a tendon. And this is also something that you usually have difficulties to find that presented in e-learning platforms or in textbooks in that concise fashion. Tendinopathy is an umbrella term in the same way as enthesiopathy. Enthesiopathy is a disease of the tendon insertion. Tendinopathy is a disease of the body of the tendon. And after all, tendons are collagen fibers, and we should view that topic in together with diseases of the anatomic fascia. And these umbrella terms cover 4 types of tendon diseases. Degenerative tendon disease and trauma, that is tendinosis or degenerative enthesiopathy or compressive tendinopathy. Tendinitis is something that should really used only for inflammation. The inflammation may be due to an infection or it may be due to rheumatic disease. And then we have a third group. These are the metabolic and toxic tendinopathies. Metabolic tendinopathies are usually due to gout, maybe calcific tendinitis or a very rare other type of crystal-induced deposits. And we should not call a gout an inflammation of the tendon because that's rather related to autoimmune diseases like rheumatoid arthritis or spondyloarthritis. And then we have toxic defects, especially some antibiotics like fluoroquinolone. And after all, we may observe some tumors of the tendons or more commonly around the tendon. What is the appropriate modality to be chosen? Probably many of you here in the room will decide for ultrasound. Probably the same percentage of the people here in the room will decide for MRI. The fact is that both are complementary modalities, and ultrasound generally in the literature is used, considered as a first line, but actually it's really depending on if you would like in your leisure time to choose for that very expensive bicycle or for that also very expensive car. It's a question of what the available is. Here, now we start with the first case. It's a 44-year-old female with painful heel. And this is the limit of her Achilles tendon. The Achilles tendon is a very good experimental model because it's not just tendon model we have. Therefore, very easy for us to understand tendon disease we will have that tendon. And what is this here? First, we should share the thickness of the tendon. We should do this routinely. And there is very specific rule of thumb. Normal tendons with normal values more than 60 millimeters are and virtually all other tendons have a cut-off point between normal and abnormal 4 millimeters. Sometimes we have difficulties to measure. An example is the cutoff, because the more it comes to the left part of the body, and then you can do it. And you can have made measure and take the cutoff. That's not possible. And what you see here is a very interesting observation. First, we see a hyperechoic rim-like enhancement with a significant enhancement around the tendon. And secondly, we see here in the anterior part of the tendon, but only in the anterior part, not that much in the posterior part, some hyperintensities. I'm not sure if you ever have kept an eye on these abnormalities, or if you just have described the Achilles tendon as being thickened or not thickened. But this is a very interesting point because it first outlines that this is tendinosis, because it's in the body of the tendon. There is no inflammation in the patient's history, and inflammatory diseases would look a little bit different. And the Achilles tendon consists of two parts: the fibers originating from the soleus muscle and the fibers originating from the gastrocnemius muscle. And that's exclusively the anterior part, more or less, in the soleus muscle. And what we also see is something that we would call peritendinitis. So this patient has severe tendinosis of the superior portion of the Achilles tendon with moderate peritendinitis. It's the most common abnormality in the Achilles tendon that you can observe. So what's happening with the term tendinosis? Tendinosis is a term that may not be observed solely in the Achilles tendon. You may also observe it in all types of tendons. And that's the secret of the concept that I'm presenting to you. It's not confined to one tendon. Abnormalities in the form of degenerative tendon diseases occur everywhere in the body. And what I'm presenting here to you are some selected cases to understand the concept, and then once you have memorized it, then there's no need for you to look up in any textbooks or so, because it's always the same for all tendons. The first point of if a tendon causes pain is functional impairment. Then the next point is peritendinous inflammation. The most simple form is tendon sheath effusion or tendovaginitis. In the Achilles tendon, you shouldn't use that term, tendovaginitis, because the Achilles tendon doesn't have a tendon sheath. This is a mistake sometimes made by people. They describe in their report tendovaginitis of the Achilles tendon, causing the orthopedic surgeons to start to laugh, because they know that that's basic anatomy. So omit this. Yeah, we have here several forms of peritendinal inflammation, tendovaginitis, bursitis, that's already mentioned. And then the next step is real degeneration of the tendon, like we have it here. That's degenerative tendon disease, with the main abnormality it is thickening and inhomogeneous structure. And as a result of it, ruptures may occur. Usually a normal tendon never ruptures, except of some very peculiar cases of sudden overuse or of a violating injury like cut with a knife or so. The tendon usually ruptures on the base of degeneration. And if a soccer player experiences a sudden hit on his heel and suddenly has a rupture, it's everything else but not a sudden event, because he, in the great majority of cases, already had experienced some pain in the Achilles tendon, sometimes for many years, sometimes he had it in the youth, and then degenerative tendon disease developed, and then he was in a sedentary professional position and started to run marathon when he was 55, and then all of a sudden it ruptures, but in fact this rupture has a long history. And we see all these historical events in the tendon with imaging, with ultrasound, high resolution ultrasound and MRI. And you see it also what happens here on an anatomic specimen. Here you see these focal lesions of a patient who was then, his corpse was dissected of such an abnormality. The Achilles tendon, as already mentioned, has a composition of two major groups, from soleus and gastrocnemius muscle, and these fascicles rotate. What you see here on this nice drawing from an anatomy publication has been described manifold in the literature, and sometimes it was theorized that here at this border is the place where tendinosis originate due to micro ruptures of the fibrillar lesions, but in fact that's not the correct point. Yeah, probably. These are a lot of hypotheses. The important is that the collagen fibers are the hypointense one or hypoechoic ones, and then we have the internal peritendin and not only the peritoneum. So what you see here is hyperintense signals, or with MRI also in a hyper-intense form. If you do real high-resolution MRI, what you can do, for instance, with a 3 Tesla machine and a very good coil and dedicated sequences, then this would also be visible slightly hyper-intense. So this is an important form of understanding it. And what you now here see is a series of images I have taken from this publication from Heraklion in Greece, from the group of Apostolos Karantanos. And what they are doing is interventional treatment of tendon pain. What you nicely see with color Doppler is that in peritendinitis, you have an increase of vessels. Normally, as you saw at the image behind, you only see one vessel, one small arterial vessel entering the tendon in the mid portion. That you can nicely see with color Doppler in almost every patient. And this is the only thing that you see in normal patients. If you see such hyper intense signals, color Doppler signals with Doppler, also within the tendon, then this is activated tendinosis. And what these groups did was to inject fluid, high volume fluid, to destroy the vessels here, with a very good result, because after treatment here you see no hypervascularization, which then was associated in this study with a relief of pain. It's very important for us to understand the importance of peritendinitis and hypervascularization. There is plenty of literature about the topic. What is the meaning of hypervascularization? It means that this is a healing process of the tendon with an associated higher risk of a rupture. Probably, once hypervascularization has been finished, I don't want to use the word tendon repair and tendon scarring, because that's something that is difficult to be defined. But once you have a stabilization after the process of healing, then the tendon tissue has become more stable, and you can allow the athlete to continue his running. But in this period, it is very difficult, and there's a high risk of tendon rupture. Here you see such a patient, 60-year-old jogger with heel pain. And you see again the concept. First, we have peritendinitis. Secondly, we have tendinosis with thickening of the fibers. Here, with an intrasubstance tear, you also may refer to it as a mucoid degeneration. So it's a question of definition, and there is no general agreement how to call it. And then the next point would be a real rupture. And this patient here, he stopped training, which is very difficult for people who are doing jogging. It needs a lot of time, it needs a lot of effort to convince them not in this acute phase to extend their jogging training, because that's the reason why they have the problem. Here you again see the overview. Peritendinitis, the cause, it's probably friction, the location, and the principles of prevention and treatment. Haglund's heel is a degenerative disease totally different from it. It's a typical form of compression, tendinopathy. That's an example of Haglund's heel. Here you have a problem of the calcaneus. Here you have the shoe. And if the shoe does not fit properly, there is compression with Achilles bursitis. The normal Achilles bursitis is this Achilles bursitis. So that's a compression. And it needs totally different treatment. Instead of this, you have to solve the shoe conflict, how it is called by the orthopedic surgeons. And then we have the tendon insertion disease. That's the typical spur. And it also needs a little different access. It's the relief of the kinetic chain. This is a typical example of such peritendinitis here, with the unsharp scars around the tendon, and here the partial rupture. This is also a very, very well-known concept in sports medicine, the intrinsic and the extrinsic factor leading to tendon overuse. The intrinsic factors are inborn in the patient's body. The extrinsic factors are from outside. And you see this list over the years has become very long. Yeah, I don't want to go through all of it, but you can imagine that age is playing a role, an important practical viewpoint, age, because if you're looking in Vienna, who is running a marathon in April every year, those old white men and young ladies, yeah, those are the people now prone to tendon disease. Yeah. Let's move to another tendon. That's a 60-year-old female with medial posterior sided foot pain. And what you see here is a tendinosis of the tibialis posterior tendon. The tibialis posterior tendon is the main, the most relevant tendon in the tarsal tunnel. And what happens here is a compression, but not only compression, it's also due to the biomechanics a tension injury, because the tibialis posterior tendon is the tendon that is mostly relevant and responsible for stabilizing the plantar dome. And once patients are starting to deform a flat foot deformity, there is an overuse, and this tendon is straightened, causing tendinitis and eventual rupture. So it's a combination of compressive forces and of tensile forces. And there is the old anatomic sentence that probably the majority of you know, that in the tarsal tunnel from anteriorly to posteriorly is the tibialis posterior tendon, thumb, the digitorum, the extensor digitorum tendon, dick, the tibial artery, the tibial vein, which may cause varicosity, thus compressing in the tunnel the tendon, and the tibial nerve, followed posteriorly by the extensor hallucis longus tendon. Therefore, for those who don't know the text, it's very simple to remind on that. Now we have another topic seen here. I try to go back to, yes. This here is a 50-year-old female with shoulder pain. And this patient had a little bump on the top of her shoulder. And somebody considered that is a tumor, some people didn't know, but it's a very distinct and typical finding. That's the so-called acromioclavicular cyst that you see here. Such an acromioclavicular cyst develops as the result of a rupture, degenerative rupture of the whole tendon complex. The patient had a fall, and what you see here is a fracture of the greater tubercle, which is a very simple diagnosis. And it's interesting here, usually, that fracture of a tubercle only occurs if the rotator cuff is intact, because the rotator cuff has a pulse on the greater tubercle. This here is a very rare case of a torn supraspinatus tendon plus a valvular lesion of the greater tubercle. Usually only this breaks or this ruptures. But in this case, well, it happened both. And what you then see is that the effusion is running through the broken tendon, the torn tendon, in the subacromial bursa. And then you need a rupture of the capsular ligaments, of both capsular ligaments of the acromion, due to degeneration, shearing forces. You have, if you move the shoulder, you have a lot of shearing forces that destroy these capsular ligaments. And then the effusion is coming out here. And somebody called it the Geyser's sign, because this person obviously had traveled to Iceland before and had observed the geysers, and therefore you have this appearance of the Geyser's sign. So you have a lot of radiological signs I only mentioned here 5 of them. If you go to this publication, then you find altogether about 10 such radiological signs in the shoulder. You have the J sign. That is an example that you see here. That is if after a luxation, there is an avulsion of the inferior glenohumeral ligament. The Cheerio sign is referring to this US American breakfast style, and is showing a rim of contrast like a Cheerio that with a part of the torn in a slab lesion of the torn labrum, and it is surrounded by contrast media. Yeah. Then you have the double axillary pouch sign. That's a case of if you have a very big destruction of the anterior inferior labrum, then it seems to look like if there were 2 pouches. And this is a very important sign because here, this is a radiographic sign, a very low image, where the humeral head is rotated in a form that you don't see the greater tubercle. It is hidden here, and this is a very important sign of posterior shoulder luxation. This here is a very interesting case that I had. This was a doctor, a physician, and once he called me and he told me on the telephone that he had recently bought a life belt. He needed the life belt because he had some pain in his buttock and the posterior thigh. And it was so painful for him that he used a life belt that you usually find on the boats, put it on the chair to sit on the life belt so that his bottom didn't have contact with the surface of the chair. And he wanted me to do MRI of that region. And I told him the diagnosis at the telephone. What do you think is that? It's a typical example of hamstring enthesiopathy, and with involvement of the posterior cutaneous femoral nerve. Do you know this nerve? It is one of the smaller nerves in the lumbosacral plexus, a very small one. And this is the image of the MRI study that was taken outside of our hospital. And if you look closely, and if you know, of course, the patient's history, then you see that here on the left side, the arrow points out on the a little bit swollen posterior cutaneous nerve compared to the right side, where you also see the arrow where it is not that much swollen. Do you see all that? Yes, because you have time to report it. Yeah? And this is the origin of the hamstrings. And you see some people are doing a lot of things with the hamstrings. This is the biceps, this is the semitendinosus, this is the semimembranosus. Very interesting observation here in this photograph of this gentleman doing exercises in the fitness studio. And this here is the anatomy. You have the semimembranosus originating here and then crossing anteriorly to the other parts of the hamstrings to the medial side. And this is the so-called conjoint tendon of both the long head of the biceps plus the semitendinosus. And these are the tendons located here, and there's another muscle, the adductor magnus tendon, located here. And once people are doing things like this, or are doing extensive jogging, then they squeeze their nerve in this triangle. And despite the nerve is embedded in a little fat pad, that doesn't help if they are doing too many exercises. This is another interesting case. This was a patient with rheumatoid arthritis, and we are now moving to the second part of this presentation, and this is, after discussing degeneration and trauma, now inflammation. This was a patient with rheumatoid arthritis, and what you're seeing here is extensive disease and destruction of the carpal wrist of that patient's right hand, and you see in a follow-up that there is, beside a small increase in the distraction of the carpal wrist, you see that there is an increase in the ulnar-sided swelling. Yeah. You see that it is significantly thickened, and this is a very distinct finding in patients with rheumatoid arthritis and also other rheumatic diseases, and typically it is observed bilaterally, and it is an inflammation with effusion of the extensor carpi ulnaris tendon that you see here. And there is a lot of differential diagnosis, mainly traumatic. So this was a case after a fall. You may also, this was also in the middle, the image also after a fall in a young gymnast with still open physical spaces. But it also may be due to overuse, and especially in extensive tennis players, it may be associated with subluxation. This is something, is an image that I took from the literature below, where you see on the fat suppressed left-sided image the extensor carpi ulnaris tendon subluxating directly the radio-ulnar joint space, whereas on the with B labeled right side, you see it in the sulcus. And what you also see here is that the patient, despite that abnormality, has a relatively deep bony sulcus. So it's always, there is a lot of variation. Some of these sulci may be very shallow for the peroneal tendon, for the intertubercular sulcus on the proximal humerus, or here on the distal ulna. So you also should quantify and estimate the depth of the sulcus. Besides rheumatic diseases, we may observe inflammatory diseases. This is something very rare. I personally only saw it in patients with diabetes, like here. This is infectious tendinitis. I guess it was the peroneus longus tendon that we had. And it needs awareness, especially if the tendovaginitis is on the hand. Because infectious tendovaginitis on the hand is mainly caused by infections through grabbing on some infective agent. And patients usually not aware of that. So if you see it and nobody knows what it is, and then they send it to the rheumatology department, because whenever somebody doesn't know the real cause of a finding, then they are sent to the rheumatology department. And then you have to ask, what did you do with your hand? The patient said, nothing. And then again you have to ask, what are you doing with your hand? And then after inquiring for several minutes or sometimes even longer, you will find out that the patient has an aquarium at home with some strange tropic African fish in it, and always is cleaning it, and then got pseudotuberculosis of the tendon sheath. So you have to combine always clinically. Cellulitis and necrotizing fasciitis is an infectious disease of the muscle compartments. And the typical form of necrotizing fasciitis, and I took it out from that publication from William Pitt from Singapore, is in this 50-year-old female, if the deep fascia are inflamed. If the superficial fascia is inflamed, like you see on the on the image on the very bottom of that slide, then you should call it cellulitis. Two different diseases, because cellulitis may be treated with antibiotics without surgery. Necrotizing fasciitis must be treated surgically. And sometimes it is not that striking as you see it on the image above, because it depends on the virulence of the causative agent. If these are especially anaerobic bacteria, then the contrast enhancement and the hyperintensity on the T2 weight images may be very, very slight. And you shouldn't underestimate that it is a very severe disease. We move now on to the third topic of this presentation, and that is metabolic and toxic tendon diseases. The most important and most common disease disease of the tendon in this group of diseases is gout. Gout has been increasing during the last 3 decades. In the 80s and the beginning of even the 90s, we weren't aware of gout being a tendon disease, and it was not observed in that common form. I don't know why, but maybe it's was a lack of awareness. And now it is important to know that we all know that on the greater metatarsophalangeal joint, the greater toe, gout that's the typical location of gout. However, the second most typical location is the Achilles tendon and other tendons. You see, gout is a disease of tendons. And if you have the chance to do dual energy CT, otherwise the best modality I would suggest is the combination of maybe radiography plus ultrasound, and maybe added with some non-dual energy CT. Then you see, like here, gout deficit in the tendon. Severe gout deficit in the Achilles tendon. A disease that debilitates gout is psoriasis. Especially if you have female patients with gout, because primary gout does not occur in females. Only in certain genetic disclosed people. Usually, if you see a CT or an image of a female with gout, then you should be surprised. Females gout, if they have an oncologic treatment as a form of secondary gout, if they have renal deficiency, also as a form of secondary gout, or if they are suffering from psoriasis. This was the patient with psoriasis, but not gout. I just had the idea, my specialty. And here, the radiograph is using normal functions. However, with ultrasound, you see the typical erosions that were all not directly located a little bit beside the contour of the posterior calcaneus. So ultrasound is very important in diagnosis and sensitization. And that is a typical diagnosis and sensitization of psoriasis. According to the model mutation, we use ultrasound because of those findings. The disease has been argued as an order of different anatomic variations that are beyond the scope of this presentation. But you see that the more complex diseases consists of 4 zones. And these are now examples with inflammatory forms of enthesiopathy in the form of enthesitis, psoriasis, ankylosing spondylitis, peripheral form with bursitis. Here you see bursitis and bone marrow edema. And here also ankylosing spondylitis with a lot of erosions. There is a totally new technique, and I'm personally convinced that we will have been dealing with it during the next years. I heard in the morning that some of you are working in the field of nuclear medicine and probably already know much better than I know about the FAPI. Do you? Yes? You're going to start. Okay. You don't have it yet. So it's exactly why I wanted to mention it. FAPI is an upcoming technique, and the nuclear medicine specialists have already started to use it or are about to starting to use it. FAPI is the abbreviation of fibroblast activation protein inhibitor uptake. And that's you nicely can observe with 68 gallium PET CT. And this is an example recently published in December by a very active group around Georg Schett in Erlangen in Germany. And they showed here a case of 3D reconstruction with all this FAPI enhancement, or with the FAPI tracer, all these enhancements in a patient with psoriasis, and that's after treatment. So it's a very promising technique, And I'm pretty sure that maybe in a couple of, what's guess, 1 year, 2 years, at least 3 years, we have to become familiar with this FAPI, which is. Another type of metabolic tendon disease is very well known to all of you. That's hydroxyapatite that you see here. And what I wanted, and that's a very nice drawing taken out from the New England Journal of Medicine. Here you have typical calcification, but what you see with MRI is the typical subtendinous bone marrow edema. And of course, it's clear that the calcification is usually hypointense and shouldn't be overlooked with MRI. But the bone marrow edema is, to my understanding, a very rare but a very important sign. Hydroxyapatite disease not only occurs at the shoulder, where we all know it, it also may be observed in the hip, as we see here. If it was related to lipid-lowering treatment or not is something that is still open and under speculation. We don't have any evidence proof of it. Sometimes it may also be observed in the spine and in the hand. These are rare cases. This is a rare disease, crystal-induced tendinopathy or arthropathy, that's hyperphosphatasia. Usually it's observed in pediatrics because the patients don't have a long life expectancy. Sometimes we see it in adults, and then it's associated with calcifications of the tendon, like here, or like here, here, and along with MRI abnormalities and osteoporosis. That's a case of an 84-year-old male with sudden bilateral severe pain in his calf. And what you see observed here is that the patient had pneumonia or a bronchial infection, and all of a sudden he had severe destruction of both of his Achilles tendons. And if you have such a typical history and have an involvement of both Achilles tendons, then this is very typical for fluoroquinolone destruction. And I would guess for about 10 years, fluoroquinolone to a high degree has been removed from the market, but not totally, because it's a very good antibiotic drug. So it's very effective, and so it's still on the market for certain cases. And therefore, we have to have the awareness to observe it. Yeah. The problem is that it probably binds ferritin and thus impairs the collagen synthesis, and then you have that abnormality that I took also out from that publication. Sorry for the images that I found in that publication. Other types of toxic tendon effects are corticosteroids. If they are given in a high dose and for a long time, not with the 5 milligrams prednisolone that the patient here in this case received. That's not enough to have that effect. Statins are still under discussion. Aromatase inhibitors also may cause that toxic tendon effect, but in this case it was a male, therefore it's not the case that we choose for that. And anabolic agents, doping is very important, but not growth hormone. It's the real anabolic steroids that may cause it. And here is the last case, and that was a swelling around the biceps tendon of the patient's elbow here. And what you see in this case is a front-like tumor. Here again, with color Doppler around it, there was some enhancement, but the lesion itself didn't have abnormalities. And that's a typical example of lipoma arborescens. Lipoma arborescens usually is observed in the knee around the quadriceps tendon, but the second most common location is this, and we discussed the case some years ago at the European Congress of Radiology. And once you are aware of it, and here again you see the same abnormality with MRI, and you see the intact biceps tendon. That's the point. And here again, the intact biceps tendon. And this is a very nice publication from Thomas Le Corolla from southern France, who also showed and documented the surgical correlation of it. And what is the differential diagnosis of such space-occupying lesions in and around tendons? It's ganglia. It may be the tenosynovial giant cell tumor. Lipoma is quite rare. Tendon sheath fibroma is also rare. And again, don't forget about gout. Nodular fasciitis is mostly seen in subcutaneous location, and rather in fascia than in tendons. So to sum up, we need to use all these terms and to become familiar with it for structured reporting. And for structured reporting, usually we need very easy to handle concepts, like in mammography, BRAT. Worldwide appreciated because it's so simple. And therefore we also need this, and that was the reason of this presentation, to give you a glimpse and an overview for a system and a concept that can be applied to virtually all tendons of the body. And once you understand the tendons, you understand a lot of musculoskeletal radiology. All these sports imaging abnormalities, they in the majority of cases are related to tendon abnormalities. And if you see a degenerative tendon abnormality, always think behind, maybe there's some underlying disease that is masked by a degeneration. Because tendons are part of biomechanical kinetic chains and anatomic complexes that need to be analyzed. A typical example is the Geyser sign that shows you that between a little palpable lump on the top of the shoulder, there is in fact an underlying rupture of the rotator cuff. So outcome orientation is also an important point. And one last word. The ancient hero Achilles, he was an athlete and a very active sportsman and a warrior. And so he had severe problems with his tendon, named after him. And there are several explanations in the Greek mythology to explain why he had problems with his tendon. One was that his mother bathed him as a baby and kept her hand on his heel. This is, by the way, a little bronze statue that has been found some years ago, very close to the Salzburg, in I would say 20 minutes drive away from it. Other explanations are that I think Apollo's arrow was directed to a person, and I think Athena, she redirected it to Achilles' heel or so. I didn't keep in mind exactly. So the living style is very important. Maybe it's in ancient Greek it was different from today, and it was a pleasure for me to discuss some glimpses behind the living style effects on tendons. Thank you.